Hi guys, it's me, Professor D, and welcome back to my YouTube channel. This is going to be part 5. This is the last part of the series for preeclampsia. And I urge you, if you haven't watched part 1, 2, 3, and 4, go watch that first so this makes sense to you. But this is the last part of the preeclampsia series. Very important if you're taking OB maternity right now, or you're studying for boards and you've gotten to your maternity portion. Preeclampsia is a concept you absolutely have to know. Yesterday or the day before yesterday, I released a video where I covered the topics that have been seen the most from my students that have gone, they took NCLEX, they passed, and they came back and they were like, Professor D, I saw this, I saw that, I saw this. And mind you, I got students from all over the country, right? And preeclampsia is definitely on that list. It popped up so many times. So that absolutely is one of the subjects you have to know. So that's that. Before we get started with this video, as always, guys, I'm going to ask you to please support me and support this channel. Like this video, subscribe to this channel if you haven't done so already, guys. And don't forget, I have audio lessons available on my website, nexusnursinginstitute.com. Okay, with that, let's get started. So where we ended off, we were doing the case studies, guys. And remember, we stopped here. It's an unfolding case study with Olga. Olga is our patient. So let's continue. So now, Olga continues with bed rest. Let me make this a little bit larger for you. Olga continues on bed rest with IV magnesium sulfate infusing. She has an indwelling catheter in place. She has continuous electronic fetal monitoring. Her respirations are now 22 beats, 22 respirations per minute. And the nurses are auscultating lung sounds every 4 hours. Assessment. What are we looking for? What are we watching out for? What pulmonary complications can occur in women with, there goes that word again, severe preeclampsia? And guys, we already went over the difference in the patients with preeclampsia with non-severe symptoms and severe symptoms. So with severe preeclampsia, those defining characteristics, what are we concerned about as far as the lungs? Dyspnea, crackles, pulmonary edema, hypoxemia. We got to make sure our patient's getting fluid, but not too much fluid. We don't want them going into fluid overload. Nursing diagnosis, impaired gas exchange, related to possible pulmonary edema that's secondary to endothelial damage and increased capillary permeability. What are the expected outcomes? We want her to exhibit normal breath sounds, no crackles, no rales, no wheezing, no rhonchi, no dyspnea. We want normal, clear breath sounds. We want adequate oxygenation. Look what they did here. In parentheses, they're telling you how we're going to know that patient has adequate oxygenation. They'll have normal respirations. The O2 sat will be 95 or higher. Remember, preferably we want it 98% or higher, but we'll take 95. Anything lower than 95, we're concerned, right? So we want 95 or higher. Full orientation. Why is full orientation important to us? That patient, we know they're awake, they're alert, they're oriented. That most likely means what? Enough oxygen is getting to the brain, because what's the first thing that happens when the patient's not getting enough oxygen to the brain? All of a sudden, they're confused. So we want full orientation of person, time, and place. We want them to be able to cough effectively. Their intake, we want it to be enough so they're not dehydrated. See? Intake will be sufficient to prevent dehydration, but we don't want to put them in fluid overload. So we want to give them enough fluid so they're not dehydrated, but we don't want to give them too much fluid and cause them to go into fluid overload. So it's definitely a balance. Continuing, nursing interventions, we're going to watch out for signs of impaired gas exchange. Again, I've said this so many times to you guys, when you're studying and you see the author put things in parentheses, they give you examples. Those examples usually tend to be your select all that applies. Make sure you know it. What are they? Increased respirations, dyspnea, altered blood gas, hypoxemia. All of those are signs and symptoms of impaired gas exchange. Okay, so now Olga's condition has stabilized with decreased pain from the headaches, and her affect is more positive. She expresses concern for the fetus and asks about his condition. She questions the nurse about how her illness might affect the baby. So assessment, what are the fetal complications that can occur when the mother has preeclampsia with severe features? So look at the defining characteristics. This is what can happen to the fetus. Intrauterine growth restriction, abnormal fetal heart rate and pattern, iatrogenic preterm birth, and placental abruption, which is a medical emergency, by the way. Nursing diagnosis, risk for injury to the fetus. Why? Because the fetus may not be getting enough, well, not the fetus, but the placenta may not be getting enough perfusion. Remember, it's through the placenta that the fetus is, oh, let me move this over for you guys, getting all the nourishment and everything that it needs. Expected outcome, Olga's fetus will remain or maintain well-being. They're giving you examples. How do we know the fetus is maintaining well-being? Adequate fetal movement, normal fetal heart rate and pattern. Nursing interventions, you're going to monitor the fetus for abnormal signs. There goes those parentheses. What are those abnormal signs? Decreased fetal activity, abnormal fetal heart rate or pattern. I've already gone over those abnormal fetal heart rates and patterns, so go watch my previous videos if you haven't done so already. We're going to maintain Olga on a side lying position. Now, let's be specific. Are you going to place her on the left side or the right side? The left side, we want to increase perfusion. And we're going to keep her informed about the fetus's status. That's going to decrease, excuse me, that's going to decrease her anxiety, okay? All right, so now let's get into the medications. Let's talk about magnesium sulfate. Magnesium sulfate is a ding, 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 ding. What does it say, guys? Medication of choice. Whenever you're reading or you're studying and you see something saying, this is a drug of choice, this is the treatment of choice, you need to know it. You're going to see it somewhere as a test question. Magnesium sulfate is the medication of choice. Look what it says, for preventing and treating seizure activity, eclampsia. When the patient's in preeclampsia, they're at risk for going into seizures, right? They go into seizures, we're now in eclampsia. We're giving magnesium sulfate to prevent this from happening. Notice the author did not say magnesium sulfate is a medication of choice for hypertension or gestational hypertension, because it's not. Yes, magnesium sulfate does bring down the blood pressure, which is wonderful. We want that to happen, but that's not the indication, okay? And I guarantee you will see that as a test question, some way, some form. You have to make sure you understand it. Take a look. It says it's almost always administered IV as a secondary infusion. That's the piggyback by infusion pump. Why? We have to be careful. We need to make sure that that patient doesn't go into magnesium sulfate toxicity. Let's keep going. Per protocol or healthcare provider's order. And guys, you have to know this protocol. I really haven't seen this. The protocol, I haven't seen this asked on nursing exams while you're in school, but I have seen the protocol, well, not with my own eyes. I haven't seen the protocol on NCLEX, but it's gotten back to me from students who's taken NCLEX as a case study. They have seen the protocol. So make sure you know this. Per protocol or healthcare provider's order, the initial dose of 4 to 6 grams of magnesium sulfate infused over 15 to 30 minutes. Then the dose is followed by a maintenance dose of magnesium sulfate that's diluted in an IV solution, 40 grams of magnesium sulfate in 1,000 mLs of lactate ring or solution, and that's the dilation that's the dilution that's happening. And it's administered, oh, sorry guys, it's administered by an infusion pump at 2 to 3 grams per hour. You need to know that. 1 second, I forgot to put my phone on airplane mode. Okay. Look at this. The dose should maintain a therapeutic serum magnesium level of 4 to 7 milliequivalents per liter. You need to know that. That is the therapeutic range that we want it to be, 4 to 7. Magnesium sulfate is rarely given IM because absorption rate can't be controlled. Injections are painful, and tissue necrosis, that's tissue death, can occur. We give it IV, it's going to be piggyback, and it's going to be on an infusion pump. If we have to give it IM, the IM dose of a 10-gram loading is a 10-gram loading dose administered as 2 separate injections of 5 grams in each buttocks. 5 and 5, that gives you the 10. If we have to give it IM, the maintenance dosage is 5 grams administered every 4 hours in alternating buttocks. Local anesthetic, remember, it's very painful. Local anesthetic can be added to the solution to reduce the injection pain. Z-track technique should be used for deep IM injection, followed by gentle massage at the site. And here I wrote in parentheses because I need to remind you guys, only if we have no choice. Preferably, we want to give this how? Intravenously. It's unclear how magnesium sulfate works to prevent and treat eclamptic seizures, but we know it does, and it does it well. Because magnesium is excreted in the urine, accurate measurements of maternal urine output must be obtained. So we're going to have a urinary catheter, and we're going to be monitoring the output. If the renal function declines, that means that patient's going to be holding on to the magnesium sulfate, right? If the renal function declines, excretion of magnesium sulfate is inadequate, resulting in magnesium toxicity. And that's why it's so important for us to watch that urine output, because if something goes wrong, kidney's not working the way it's supposed to, mom's not getting rid of the urine, guess what she's not getting rid of? That magnesium sulfate. Common side effects of magnesium sulfate are a feeling of warmth, flushing, diaphoresis, and burning at the IV site. I highlighted this in pink. This is important. You need to know those signs and symptoms of magnesium toxicity. Let's go over them. Symptoms of magnesium toxicity include absent deep tendon reflexes, because remember what magnesium sulfate does. It relaxes those muscles, the uterus, relaxes those contractions, right? So absent deep tendon reflexes, respiratory depression, blurred vision, slurred speech, severe muscle weakness, and cardiac arrest. Notice I put NCLEX over here and NCLEX over here. You better know them. It's been seen on NCLEX so many times. Blood can be drawn to determine the serum magnesium level if toxicity is suspected. Remember, we want to keep the magnesium sulfate level between what? 4 and 7. Look at this medication alert. High serum levels of magnesium can cause relaxation of smooth muscles, such as the uterus. Here's another nursing alert. You see, I got NCLEX and stars all over it. If magnesium sulfate toxicity is suspected, prompt actions are needed to prevent respiratory or cardiac arrest. The magnesium infusion should be discontinued what? Immediately. This is a rule of thumb, guys. Anything that's harming a patient, the first thing you're going to do is stop that infusion. Why would you keep something infusing into a patient that's harming them, that's killing them? The first thing you're going to do is stop that infusion. Next, look, calcium gluconate or calcium chloride, that's the antidote to magnesium sulfate. That's what's going to be administered. That can be given IV. So you're going to stop what's harming them, which is the magnesium sulfate if they're in toxicity, right? And then make sure you have that calcium gluconate, calcium chloride on hand. Let me tell you something. That patient is getting magnesium sulfate. You better have this antidote available already nearby in case you need it. Never, ever, 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 ever abbreviate magnesium sulfate as, and this is a symbol, the magnesium SO4 anywhere in the medical record. Why? This is a high alert drug. Look what it says. Magnesium sulfate is considered a high alert medication because it can cause patient harm when administered incorrectly. So you need to write out the whole word magnesium sulfate, okay? Let's talk about control of blood pressure. Antihypertensive medications are indicated for control of blood pressure, not magnesium sulfate. Antihypertensive medications are indicated when the systolic blood pressure exceeds 140, diastolic blood pressure exceeds 110. To maintain the uteroplacental perfusion, antihypertensive therapy must not decrease arterial pressure too much or too rapidly. Here's the thing, guys. If you drop the blood pressure too fast, guess what you can do? Throw that patient into seizures. Yeah, so we don't want to drop them too fast. Look at this, hydralazine, the betalol, and the nifedipine are effective drugs for treating hypertension intrapartum. They may also be used during pregnancy or in the postpartum period for blood pressure control. Hydralazine, number 1, that's why I put the star next to it. But all of these drugs, all of these hypertensive medications, this is what we give the patient to control the blood pressure. If we're talking about controlling blood pressure, these are what one of these is, or maybe a cocktail, depending on the patient's condition. That's what we're going to give them for the blood pressure. If we're talking about seizures and preventing seizures, that's when we're talking about magnesium sulfate. Do not confuse the two. All right, postpartum care. Throughout the postpartum period, the woman needs careful assessment of her vital signs, intake and output. You're going to check her deep tendon reflexes, level of consciousness. The magnesium sulfate infusion is continued after birth for seizure prophylaxis as ordered, usually for 24 hours. Here's the thing. When mom has preeclampsia, what's causing the preeclampsia is a fetus. Once she gives birth, she's relatively safe, but we're not taking any chances. That's why she's still going to get that magnesium sulfate for another 24 hours after birth. We don't want her going into seizures. So we're going to continue that for seizure precaution. Assessment for effects and side effects continue until the medication has been discontinued. The signs and symptoms of preeclampsia usually resolve within 48 hours after birth. Giving birth, that is the key. The nurse should assess the postpartum woman regularly for any symptoms of preeclampsia. How many times have we seen the symptoms? Many times. That's because you're going to see that's a test question. You better know it. What are those signs and symptoms? Headache, visual disturbances, epigastric pain. Some women develop signs and symptoms of preeclampsia for the first time after giving birth. Women who develop hypertension and severe features of preeclampsia, such as headaches or blurred vision or severe hypertension, should be placed on magnesium sulfate for seizure prophylaxis. And they'll be on that for a couple of days. Women should be taught to contact their healthcare provider or return to the hospital immediately if they develop headaches, visual disturbances, or epigastric pain after discharge. Throughout this entire teaching, I've seen this headache, visual disturbances, epigastric pains at least 5 times. For women with gestational hypertension, preeclampsia, or superimposed eclampsia, it's recommended that the blood pressure be monitored in the hospital or that equivalent outpatient surveillance be performed at least 72 hours after birth. If the blood pressure, the blood pressure should then be rechecked 7 to 10 days postpartum or earlier in women who are symptomatic. Women with a blood pressure of 150/100 or higher on 2 occasions that are 4 to 6 hours apart should be placed on antihypertensive medication, and usually they'll either be placed on labetalol or nifedipine. Ideally, women who have preeclampsia in a previous pregnancy should receive counseling during a preconception visit before the next planned pregnancy, because the chances are very high she may have preeclampsia again. Potential lifestyle modifications. This is important. You need to know this. I don't know why I didn't highlight this in a different color. I don't have another color highlighter, but this is important for you guys to know, these lifestyle modifications. Weight loss, increased activity, they should be encouraged because that helps bring down the blood pressure. The current status of any chronic medical condition, such as diabetes or chronic hypertension, should be assessed so that they're brought to the best control possible before an upcoming pregnancy. The use of low-dose aspirin during the upcoming pregnancy will likely be recommended, especially if an adverse outcome accompanied the previous pregnancy that the woman had with preeclampsia. Now let's look at these medications, some important things you guys need to know. Let's start with hydralazine. It's a arteriolar vasodilator. That's how it helps bring down the blood pressure. Nursing actions, we're going to assess the blood pressure frequently. If giving multiple doses, you're going to wait at least 20 minutes after the first dose is given to administer an additional dose. Let me tell you something. Hydralazine is no joke. Like, you have your normal, antihypertensive meds, and when none of them work, that's when we go to hydralazine. Hydralazine is the big guns, right? So when you give a patient hydralazine, you need to wait 20 minutes before you say, oh, this blood pressure is not going down. And then you call the healthcare provider for orders, and they might order a higher dose or something else. This is very strong. So wait at least 20 minutes to see if that blood pressure doesn't go down. You're going to make sure the patient stays on bed rest, side rails up. Use with caution in the presence of maternal tachycardia. Be very careful if that patient has tachycardia. Labetalol, something important to know about that medication, do not use in women with asthma. Labetalol is what? A beta blocker, okay? Heart disease or congestive heart failure. This medication, labetalol, do not use in women that have asthma, heart disease, or CHF. Do not exceed 80 milligrams in a single dose. Do not give more than 300 milligrams total in 24 hours. Methyl-dopa, I added this just for you to know that this medication is given as an indication for hypertension in pregnancy. And nifedipine, it's a calcium channel blocker. Important things to know, you're going to avoid concurrent use with magnesium sulfate because skeletal muscle blockade can result. So you're not going to give nifedipine at the same time that you're giving when the patient's getting magnesium sulfate. Avoid immediate release or sublingual form due to increased risk for profound maternal hypotension. One more thing I want to cover with you guys. Care of the woman with preeclampsia that is receiving magnesium sulfate. And you know it's serious because I wrote no with 3 exclamation marks. So patient family teaching. I'm not going to go over all of these line by line, guys, but you can pause to read. But the most important things I will cover, but pause to read for yourself. You're going to explain that magnesium sulfate is used to prevent disease progression. We don't want mom to go into seizures. Explain that magnesium sulfate is used to prevent seizures, not to decrease blood pressure. If you guys get anything from me out of this whole series, get this, okay? So reactions to expect from the medication, this has been seen on NCLEX many times. Initially, the woman appears flushed and feels hot, sedated, and nauseated. Those are side effects of the medication. You have to warn them in advance. She may experience burning at the IV site, especially during the bolus. Monitoring to anticipate. So for the mom, you're going to check that blood pressure, pulse, respiration. You're looking at the deep tender reflexes. You're checking the level of consciousness. You're checking the urine output, and you better make sure she has an indwelling catheter. You're going to assess her for headache, visual disturbances, epigastric pain. And for the fetus, you're going to be checking the fetal heart rate and activity. Let's talk about administration, magnesium sulfate. You're going to position the woman side lying, again, preferably on the left side. Piggyback solution of 40 grams of magnesium sulfate in 1,000 milliliters of lactate ringers. Remember, it's going to be diluted solution with infusion control device, always on a pump at the ordered rate. The loading dose, initial bolus of 4 grams to 6 grams over 15 to 30 minutes. Then the maintenance dose of 2 grams per hour according to unit protocol or specific physician's orders. Make sure you guys know that protocol. You're going to monitor the blood pressure, pulse, respirations every 15 to 30 minutes, depending on the woman's condition. Monitor the fetal heart rate and the contractions continuously. She's going to be on an electronic fetal monitor device, so we can keep an eye on that. Restrict fluid output intake to a total of no more than 125 milliliters per hour. The urine output should be at least 25 to 30 milliliters per hour. Reportable conditions, know all of these, guys. What are the situations that you have to call the healthcare provider right away? This is a list. Blood pressure of more than 160 systolic and more than 110 diastolic, respiratory rate less than 12, urinary output less than 25 to 30 milliliters per hour. The presence of headache, visual disturbances, decreasing level of consciousness, or epigastric pain. Increasing severity or loss of the deep tendon reflexes, including them now having edema, proteinuria. Any abnormal laboratory values. Remember, we want that magnesium sulfate to be between 4 and 7, right? So anything outside the norm for magnesium sulfate, platelet count, creatinine clearance, levels of the uric acid, AST, ALT, prothrombin time, the PTT, fibrinogen, fibrin split products. And we talked about all of this already. You know why. So you see any abnormalities in them, you need to report that right away. Any other significant change in maternal or fetal status. Last, emergency measures. you better keep emergency drugs and intubation equipment immediately available. You better have that airway kit right there at the bedside. You better have that calcium chloride right there at the bedside. You better make sure you keep the side rails up, keep lights dim, maintain quiet environment. Remember, we're trying to decrease stimuli. We don't want mom going into seizures. And that is it, guys. That is the end of this 5-part series on preeclampsia. Please let me know what you thought about this video in the comments. Let me know what you'd like to see more of. And don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. Thank you so much for watching this video. You guys will catch me on the next video.